I'm Dr. Allan Perel, and this is Conversations in Medicine. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge medical topics to the Staten Island and tri-state community. Today's topic is oncology, the medicine of cancer. We will discuss and hope to try to allay some of the fears around cancer through information and education. Information is power to the patient, the family, and of course to the healthcare provider. My wonderful and esteemed guests today are Dr. Tom Florenza, Director of Oncology at Richmond University Medical Center, and Melissa Lanza, who's an RN and a nurse practitioner with an extensive background in oncology. Thank you both for coming.
Nice to be here, Allan.
Melissa, tell us a little bit about what a nurse practitioner is for our audience.
A nurse practitioner is a primary healthcare provider, and we provide primary care. We diagnose, we treat, and prescribe for patients, and we also do prevention and screening to prevent different illnesses and keep people healthy with immunizations and, testing and screening.
And I know you have a practice on Staten Island.
Yes.
Thank you. And Tom, tell us a bit about oncology. I know you're the director of the oncology department at a major hospital at Richmond University Medical Center on Staten Island.
Yes.
Tell us a little bit about oncology and how someone becomes an oncologist.
Well, obviously you go to medical school first, and then you do 3 years of residency training, usually in internal medicine, and then there's another 3 years of training in the subspecialty of oncology and hematology. And now, since there have been so many advances in oncology, they're doing subspecialization training. So for instance, in bone marrow transplantation, thoracic oncology. And for the surgeon, it's 5 years of surgery, and then a fellowship in a particular area that interests them.
So there's a lot of training,
Yes.
and it takes a lot of time to get there. And there are subspecialists in different areas of oncology. You said surgical oncology and medical oncology. So let's talk about oncology in itself, the fear of cancer. As past president of the Medical Society and as a practicing neurologist, yes, I see people with cancer many times, even if they don't come in primarily for that diagnosis. What I've heard and what I've seen, and what I've seen some statistics from New York City and from the tri-state area, is that Staten Island happens to have one of the highest risks or rates of cancer, different kinds of cancer, in all of New York. What do you think about that? Do you know why that's happening, and what can we tell people to do about it?
Well, there's been various theories on why this happens. It is a fact, unfortunately. We did a study back in the late 80s looking at the prevailing winds, and it appears that the winds from Jersey hit the North Shore. So there's a higher incidence on the North Shore than the South Shore. So it has nothing to do with the dump that's on the South Shore. There's a higher incidence of obesity on Staten Island. Why that is, I don't know. And obesity is associated with cancer development and also recurrence after you have had the diagnosis and possibly been cured of it. I don't know necessarily that Staten Islanders exercise less, but that is also something that's associated. But probably the biggest thing, and unfortunately it's rising in our teens, is smoking. If people could stop smoking, most of cancer would disappear. All of the major cancers that everyone fears of getting are associated with smoking. So your risk can be cut in, I would say at least in half, because you need 2 hits to get cancer. You
What
have
do you
to
mean
have,
by that?
Well, there's a predisposition. We have what we call cancer genes. They're called oncogenes. And this exists in all of us. But if we take care of ourselves with exercise, if we eat properly, we don't get what's called a second hit. So if you are exposed to carcinogens, let's make it simple. So if you have asbestos exposure, This works in conjunction with your oncogenes, and with the 2 hits, the second hit being the asbestos, you're more prone to get lung cancer or lung disease. So it's not just one thing that will give you cancer. So you can try to prevent it and reduce your risks.
Is there any supplements or pills or things that people could take? Everyone's afraid of getting cancer. Is there any magic bullet that's out there?
There's no magic bullet. What there is, though, is healthy living. Now, this may be different for everybody, but if you can try to keep your weight in what's national ranges called, your body mass index, your BMI. Most people are a little high on that, but it's been shown that with weight reduction, you can affect diabetes, you can affect hypertension, but you can affect cancer also. So maintaining your weight, maintaining a minimal amount of exercise, the recommendation is 3 times a week, a half hour. You can't say that's going to prevent cancer, but if you're healthier, you're less likely to contract it.
So there really is no pill, nothing you can get at a vitamin store that will dramatically affect this?
Nothing has really been shown definitively. Antioxidants, I mean, in the lab, in theory, they all have a role in cancer production and cancer treatment also. We'll talk later on possibly about the radiation. The way it works is by producing antioxidants of free radicals. So if you're taking an antioxidant while you're on radiation, you're sort of counteracting that. So one thing I can say for sure, if you're getting treatment, chemotherapy or radiation, you should not be on vitamins. Because it could interfere with the mechanism.
That's very interesting. That's why I think with all physicians and healthcare professionals, people are always told, please come in with a list of everything that you take,
Yes.
including herbal supplements, vitamins, and other things like that.
Yes.
People always ask me why, because there are always interactions between it. You mentioned smoking before, and clearly that's so crucial for all of us to talk to our patients about it. And just reducing smoking, because smoking is involved with almost every neurological disease as a neurologist. MS risk is higher with smokers, of course, stroke risk, things of that nature. So it's very, very damning to smoke.
And something that people aren't aware of, they think, well, if I don't use cigarettes, tobacco, I can use marijuana. Same risks.
Really?
Same damage to the lung. So that's the second hit. So if you have something in your lung, say you have been exposed as a child to something, and you have scar tissue in your lung, if you don't insult it with smoking or obesity, it probably will just stay that as scar tissue.
So Melissa, let's go back to the primary care portion. So when people come to your office, you're seeing patients on a daily basis, and you work at the hospital, and you do a lot of teaching, I know. What kind of screening do you talk to them about? People are always concerned they feel a little lump or a bump under their skin. And then they don't go to an oncologist if they feel it. What is your role, and how do you talk to patients about it?
Well, yes, in primary care, I try to really focus on the prevention. And I with education as well, I educate the women to do breast exams on themselves, to do that monthly, to check, and they're instructed how to give their own breast exams. They're also instructed, women are instructed to follow up with their mammograms. And the recommendations are to have, after 40, to have a mammogram every year. However, in some cases where if the mother or if there's a very strong family history of breast cancer in the family, directly like the mother, that you would try then to see if that woman can be screened at 35, to make sure, to get a baseline at 35, and then definitely after age 40. But basically to really to focus on the screening and to follow up with those tests. I also instruct the women to make sure to prevent cervical cancer, that they go for their pap smears, that they follow up with the gynecologist to get their pap smears, to do that faithfully. In males and females, the recommendation is at age 50 that you should have your colonoscopy. And then with males, I also make sure that they get their PSA tested as well.
That's for prostate cancer. And so marvelous. I mean, and that's so important to impart that. sometimes people go into their doctor and say, and I ask, have you seen your internist or your healthcare professional, your primary care person who's seeing you? How often do you go there? I only go there when I have a sore throat. I only go there when I'm not feeling well. But the idea of this type of prevention is really what helps prevent people from needing to go sometimes to the oncologist or needing more advanced care and having a much better outcome. So Tom, talk to us a little bit about where we're going now with oncology. If somebody, who gets referred to an oncologist?
Usually it comes from the primary care community, the nurse practitioner, a family practice doctor, an internist. A patient will go to them with something that's not getting better in their body. So if you notice a swelling that doesn't go away after an appropriate amount of time, usually we say 1 or 2 weeks, or it's getting larger as you're looking at it. If you're losing weight and there's no particular reason for it, I mean, it could be many reasons, doesn't mean you have cancer, but it's something that needs attention. So I usually get referrals from an internist. They may want me to decide which way to approach it, whether I do a biopsy first, taking a piece of the tissue say you have a swelling in your neck, and we would send you to a specialist, an ear, nose, and throat specialist, so they could look directly into your throat. If you're a smoker, let's say, you're more likely to get throat cancer. So the first thing is to determine where the cancer is coming from. Once that's done, then there are specific prescribed treatments for each part of the body, and each cancer, I should say.
So everything is different.
Yes.
So to our population of people out there, does everyone die from cancer? If you have a diagnosis of cancer and you're told you have cancer, and then again, I'm not talking about maybe a small skin cancer that we all talk about, but if someone has a cancer of an internal organ, is that a death sentence?
Not necessarily. I think we have to accept the fact that we're all going to die. So, I mean, you shouldn't live in fear of dying. If you encounter a cancer in your lifetime, it has to be dealt with. That some cancers are more difficult to treat than others. And we're entering a whole new era of cancer treatments where we're not using chemotherapy, we're using immunotherapy. So what immunotherapy is where we've learned over the years, we knew actually in 1970 about something called Coley's toxin, where people that would get high fevers, they would inject them with this toxin to give them high fevers, they did better. And so over the years, we learned that the body's immune system can really counter cancer. So what happens is that the T cells, which are cancer-fighting cells, let's just keep it simple at that, get blocked by the cancer because the cancer's smart. It's on the defensive. So what it does is it produces a protein, and it interferes with the functioning of the T cell. So the first disease that really got under immunologic control was melanoma.
Which is?
Which is cancer of the skin, usually due to sun exposure. So the melanomas around the beginning of this century began to get really well controlled with immunotherapy. And we fight it with 2 different ways. And what these drugs do is it interferes with the interference that the cancer is causing. So the immune system takes over. And we've seen some incredible responses. Melanoma with liver full of cancer disappears after maybe 6 months of treatment. And there's not chemotherapy side
So that gives us
effects.
another avenue of therapy.
Yes.
So we've all heard of radiation, chemotherapy, and we'll talk maybe a little bit more about them in a moment. But this concept of immunotherapy, that's a big deal. That's something very different, isn't it, over the last 5 to 10 years?
Yes, and now it's been extrapolated to the last count, at least 15 or 16 different cancers. So it's depending on the mutational rate of the cancer. The higher the number of mutations, which is defects in the DNA in the tumor, the more likely they are to respond to immunotherapy, because the mutations lead to what we call antigens, which stimulate the immune system and block it. in the cancer. So if the more mutations you have, the more antigens you're presenting, and the more likely you are to respond to immunotherapy.
And in general, all cancers are secondary to some kind of a mutation, some type of a problem with the DNA.
Yes, yes. It all stems from the DNA.
And as a neurologist, physician, it always boggled my mind why your body doesn't attack the cancer. If I have a splinter, it'll attack it. If I get a cold or a sore throat, there'll be a huge immunological response. But as you said, the cancer is very smart. It wants to survive and it wants to grow. And the idea of being able to unmask the immune portion there is something that I think is crucial and I think is really amazing of what's happening.
That's been one of the greatest breakthroughs we've had. I mean, the three traditional modalities, surgery, chemotherapy, and radiation still exist, and they're still a cornerstone of the diagnosis and treatment of cancer. Chemotherapy and radiation, obviously not diagnosis, but surgery is still a major part. You need a biopsy, so you have to know what you're dealing with. And with the biopsy, we can determine the mutations, the chromosomes in the cancer, which will lead us in a particular direction. And if you look at the evolution of the surgical intervention in cancers, it's very interesting because if you look back to, let's say, breast cancer, there was a gentleman called Halstead who would advocate you had to remove the last bit of cancer from the chest wall, and we used to do these very mutilating procedures. And this has evolved through the work of Bernie Fisher in the 80s, to where we prove that you don't have to remove the whole breast. You can do a lumpectomy, just take a part of the breast tissue which has the cancer in it, stage it looking for the lymph nodes, and preserve the breast. So understanding that cancer is a systemic disease and not necessarily just localized. That's why the chemotherapy became important in the late 80s and 90s. And now with the immunotherapy, we're actually counteracting what has been obstructed by the cancer.
So Melissa, when a patient comes in and has cancer, they have something, whether it's on their skin, their breast, their stomach, wherever it is, and they go to an oncologist, and Dr. Florenz has really given a very eloquent talk about surgeries and everything else. Then they come back to you. How do you advise them? I mean, there's part of things that we could do, and as a neurologist, sometimes I have patients who have brain tumors and other kinds of tumors, and my expertise is understanding it but not really treating it in similar ways to the primary care healthcare provider. I'm there for a lot of spiritual help. I'm here to advise them and say they're doing the right thing. What do you do when someone comes in and has a diagnosis of cancer?
Well, when they come to me and they come back from the oncologist and they hear this devastating news, as their primary, I have to kind of put the pieces back together and help them to give them support. So we follow, of course, when I consult, and if the oncologist advises the patient for the certain treatment plan, then I go over that with the patient to find out, is that the goal of care? Is that what they want to do? And some of them will say, well, I really don't want to, the oncologist recommends that I have surgery or this or that, and I really don't want that. I just want palliative care or just to be, just to leave it alone. And they come to me for spiritual support and emotional support. And so I have a tool in the office. I have this journal. Journaling is, this book, it's Experience God's Presence. This is a tool that has been very helpful in providing spiritual support for the patient, the caregiver, and the client. The client, the caregiver, and the family. And it really helps to give them support. And then I go along with what their desires are to figure out the goal of care, if what they really want, and then I follow through with that.
And that's what's so important. And tell me, Tom, I mean, let's talk about the team. So, of course, the patient's part of the team, the primary care physician's part of the team, you're an integral part of the team as the oncologist, the surgeons, all those people, and the family, of course.
Right.
Tell me how they all work together, and does it really matter if everybody's on the same page, if everybody's understanding what your goals are for therapy and what treatments and what side effects you might have?
Yes. Can
Thank
I just yes. Now, everyone eventually has to come on the same page. And invariably, no one is ever on the same page at the same time, because when you get this diagnosis, it does a few things. First, it tells you that, yes, I may really die. That fear has to be addressed. Yeah, this thing could actually come to an end, Secondly, I have to go for treatments. I have to do this. I have to do that. Who's telling me I have to? Yes, you have to do these things. So your lifestyle is going to change. So your spouse, oh my goodness, that means I may not be able to do this because I have to take him to treatment or I have to take my wife to treatment. Yes, your lifestyle has changed. Your children, same thing with them. So we have a team at the hospital. We have the nurse, we have a social worker, pastoral care, that all support you during this. And the internist is obviously very important also, because most of the time your internist is knowing you for the longest period of time. And he or she will know your family or your personality better. But then the oncologist really, as we get into the treatments, which with the immunotherapies now they can go out at least to 2 years. So a lot of your care is being done by the oncologist. A lot of your support comes from him and his staff or her staff. So it is certainly a team approach, but there's two teams. There's the patients and their team and the doctor and his team, and they both have to learn how to talk to each other.
And I think the term is it takes a village to have a child go through school, and especially with oncology, it really does take a village, and everyone has to be on the same page. So if someone is diagnosed with having cancer, and I can tell you we have a wonderful audience. I'm so proud of them and the questions that they ask, and my patients, and just living on Staten Island and being in one of the outer boroughs of New York City, my patients will come to me invariably, and I'm so proud of the healthcare on Staten Island, out here and some of the other places that I've worked. What do you think when a person comes to you and says, if someone has cancer, could they be given good treatment, the best treatment, on Staten Island or in outer borough or somewhere not in Manhattan or at a major university with the things that we think about and we see on television? And I think that just becomes a question. Does everybody need a second opinion? Does everyone need a second opinion at a place like Sloan Kettering in the city? And what are both of your thoughts about that? Because patients, I'm sure, ask you this every day.
Oh, we get this frequently. As I said, this is a life-changing event. You have to see how you feel. Now, most oncologists that I work with, that I know on Staten Island, know their limits. When I have a very rare tumor that I may treat once or twice a year, it's my practice to get another opinion at some place in the city. I think we're very fortunate to live so close to major medical centers because you have subspecialty experts. So that's why I have affiliations with 2 major medical centers in the city where I can just pick up a phone and call a colleague up there. And I have no problem if the person wants to go for a second opinion. Because if we're giving the same treatment, why should you have to travel into Manhattan or Brooklyn or Jersey to get a treatment you can get on Staten Island?
And I think that's so important that you have the connections. I've trained in Manhattan. We're all part of many university systems in Manhattan and throughout the country. The idea that we have the availability to call someone to maybe just run it by them. And basically go from there. And as you said, knowing your limits is crucial.
Right, absolutely.
If someone has this very rare tumor, that there's a 1 in a million type of tumor, you really want somebody who sees a constellation of this. And in a place like Manhattan, sometimes we do get some of those major centers. And sometimes even the people at major centers in Manhattan send people to other places like the Mayo Clinic or Texas, MD Anderson for other input with it. So being a physician, what I've learned most about this is that we ask each other things. You know, the key word in the hospital, and we do when patients come to our offices, it's the word consultation. And what does that mean? We give them our opinion. And we take that opinion back and we see what they come up with it. So Melissa, tell us a little bit about when people say that they want to get care in different places, do you encourage them, or you know, what kind of thoughts do you have?
Well, I always take account the population of I always let the patient make that decision. For example, I have found in my experience, the elderly, if they have this diagnosis of cancer, a lot of the elderly, they really tell me that it would be a hardship for them to go into Manhattan, and they have shared with me that they rather not go into the city. So then again, I have to look at where the patient's coming from and respect their opinion, but I always give them options. I tell them, you know, you have this diagnosis, and here are the options if you want a second opinion, if you want to go to another place in Manhattan, or if you want to go to Jersey. You know, that if you wanted another evaluation, you can have that, and if you didn't, that's entirely, you know, up to the patient, and I throw it back on the patient, you know, to let them make the decision to come up with the plan.
We're running almost low on time, but I'm going to ask you just a couple of quick, like 2-second questions. People ask me this all the time. What's a PET scan?
It's not a CAT scan.
PET.
We must like animals. A PET scan is where they inject a nucleotide. It's not the contrast dye that you get with a CAT scan, and it shows the metabolism. Metabolism. It's the functioning of a particular tumor, but they can't distinguish between a tumor or, say, a lung pneumonia. So just because your PET scan is positive, it doesn't mean that you necessarily have cancer. We use it in the staging of cancers, and once we have a diagnosis, then you can make the assumption. But it's a test that takes about 45 minutes. There are some restrictions, dietary restrictions and so forth. You have to lie still, but it's a very effective test in what we call staging of the cancer.
What's a remission?
A remission is when there's no detectable cancer.
Are patients with cancer ever cured?
Yes. Yes.
So a remission doesn't mean a cure, clearly, but how do you tell the difference between them? And how do you tell that to your patients?
The magical number of 5 years is looming out there, but there are certain cancers where if you don't have anything after 2 years, say with testicular cancer, if there's no sign of recurrence after 2 years, you're considered cured. So it really does vary. It depends the rapidity with which you respond to whatever modality of treatment you're getting. But yes, you can be in remission. Certain cancers do have delayed recurrences. That's why you need to follow up with your oncologist in particular, or your internist if they're into cancer screening, because there may be some subtle changes, and as with any cancer, if you catch it earlier on, it's much better.
Super.
So that's why you say, why am I seeing this doctor for 10 years? And
we're going to wrap up. I want to say thank you to both of you for being here. You've really enlightened us. And I hope to our audience that we're able to take some of the fear out of this. We've come such a long way. And one day we hope to say that there'll be a cure for cancer. I want to thank everyone for watching. And I want to thank my wonderful producer, the best in the world, David Marcos, for all his work in making this show a success. Thank you.